We invite Dr. Aanchal Thakur. She is going to present on management of post-cataract surgery corneal fungal tunnel infections, review of a large case series. We will request next speaker, Dr. Aparna Nayak, to be ready.
Good morning, everyone. I will be speaking on management of post-cataract surgery, corneal fungal tunnel infections, review of a large case series. So it was a retrospective case series, and we have 16 patients who underwent corneal scrapings where there was epithelial defect with infiltrates, anterior chamber tap and vitreous tap in patients where vitrectomy was performed for endophthalmitis. The clinical features, lab workup and different management outcomes were analyzed. So we all know that phaco-tunnel infections have a delayed presentations because of a deep corneal intrastromal infiltrates with an intact epithelium and a good visual acuity for a long time. It is very difficult to establish the causative organism because obtaining a sample is a major challenge. Moreover, they are non-responsive to the conventional treatment because most of these eyes are steroid exposed. And usually these patients, they develop concurrent endophthalmitis or they develop endophthalmitis during the course of the disease. In India, we know that bacteria is the most common cause of endophthalmitis, although in another part of India, fungi is the most common organism leading to endophthalmitis. So I'll start with my patients. I'll be describing few of them because in view of time I cannot describe every patient. So in case 1 and case 2, both these patients had a fungal phaco-tunnel infection. The first patient was positive for Candida on vitreous tap and the second was positive for Aspergillus. Even on repeated intracameral intrastromal injections, the patient was not resolved, the infiltrates were not resolving, and the first patients went for a patch graft. Also IOL explant and pars plana vitrectomy was done. In the second patient, the patient presented with a 6/6 vision and there was a side port fungal corneal tunnel infiltrate. After repeated intracameral intrastromal injections, it was not improving, and finally the patient had to undergo a pars plana vitrectomy with IOL explant. There was a big fungal ball behind the iris, so the iris was also cut. But finally, after 4 months, the patient was 6/9 with aphakic correction. These were other 3 patients. I'll be describing some important ones. Like in the case 7, the patient had a intrastromal fungal corneal infiltrate, and it was again PCR positive for panfungal genome. This patient had a superficial lesion. It was like extending up to 350 microns of the cornea. So even after intracameral intrastromal injections, which we repeated 4 to 5 times, there was no resolution of the infiltrates. So finally we went ahead with the PAC CXL or cross-linking for the limited area of corneal ulcer, and finally the patient healed after 3 weeks of cross-linking. I would describe case 13 and 14 in which there was hypopyon and intracameral exudates. It was a fungal ball in the AC. So both these patients, they resolved with repeated intracameral intrastromal injections, and finally there was a membrane at the level of the IOL. So after the resolution of the corneal infiltrates, a membranectomy was performed, and both these patients regained vision of 6/9 after membranectomy. These were very subtle infiltrates, case 15 and case 16. There were infiltrates, just very subtle infiltrates on the main port. The first patient, the sampling was not possible and we just gave empirical topical natamycin and the patient resolved. Case 16, we tried to do a intracameral, we tried to do aqueous tap, but it was negative. But we still went ahead with intracameral vozole and the patient resolved after 4 weeks. So coming to my results, the median interval to onset of symptoms was 11.5 days. Corneal infiltrates with endophthalmitis was present in 87%. Only corneal involvement in 12%. Main port in 18.7% and only side port in 68.75%. Microbiology positivity could be attained in 53% patients. Most of them were Aspergillus fumigatus with Candida in 1 and PCR panfungal genome in 3 patients. The most common management modality in my case series was pars plana vitrectomy along with intracameral and intrastromal injections. The time of resolution was 9.7 weeks in 13 patients. 1 patient was lost to follow-up and 2 patients went into phthisis bulbi. These 2 patients had severe endophthalmitis and they developed serous choroidals. Although the corneal infiltrates were resolving, still they went into phthisis. This is just brief about the number of intracameral intrastromal injections. Limited studies have been published with the very poor prognosis in one study with 7 eyes with proven fungal infection. So I would just like to highlight that post-cataract surgery, fungal tunnel infection, they pose a diagnostic and therapeutic challenge. Different management strategies can be planned according to the clinical situation With promising results with intracameral and intrastromal antifungal injections alone, PAC-CXL appears to have a promising role in certain recalcitrant fungal tunnel infection when the infection has not gone beyond the deep stroma. Thank you.
I was interested to know, see, you had so many of the tunnel infections. Like, what was the primary cause for having a tunnel infection? What was the basic primary cause? Whether patient immunocompromised or was something?
Out of 16, I had 4 patients who were diabetics. Although we say that diabetics are more prone to getting fungal tunnel, but they are all referred to the tertiary eye center. They were not in-house cataract surgery. They all were referred from outside, and it's a period of around 1 year. So I just collected those patients. And
So, but your statistics is just 4 patients of diabetes. Then what about the other patients?
Pardon?
What about the other patients? What was the primary cause? See, to have a fungus infection, something should be a cause, right? So, what was the primary cause? Why did they develop it?
Post-cataract infections can develop because of so many reasons during cataract surgery, sterility and...
Were they all culture positive? Were they all microbiologically proven fungal infections?
53% were culture positive.
So there was a bunch of people in whom you have given presumptive antifungal treatment.
Yes, ma'am. Very, very subtle infections on the tunnel where we can see those whitish fungal balls. We are just presuming it fungal because the sample could not be obtained in 2 patients.
So what were the antifungals used?
Antifungal was standard. For intracameral, intrastromal, we used voriconazole. And for topical, we used natamycin and voriconazole both.
And between intracameral and intrastromal injections, how did you decide?
Most of the patients received both, where they had hypopion in the anterior chamber and a corneal infiltrate, we gave both. If there was only corneal stromal infiltrate, we gave only intrastromal. But
I'm
most
very
of the
surprised
patients
that all of them have done very well, which is not the situation usually in a fungal infection. You've not lost any eye or you did not have any recurrence. It's pretty unusual in fungal tunnel infections.
We lost, ma'am, 2 eyes, 2 eyes
okay,
with
fine.
incisions. And 1 patient lost to follow-up. So sorry.
You did this PAC-CXL, no? For how many patients did you do?
We did for 3 patients, PAC-CXL.
How did they respond?
And they were not involving the deep stroma. They were just 350 microns of the anterior stroma. So they did well, both these patients.
One person is not coming.
Dr. Lok Sati and Dr. Ashok Sharma.